I have been to several healthcare reform seminars in the past 2 to 3 years. Some conveyed panic, some confusion. How many have gone to one of those seminars the past few years? Okay, not that many, but... So what do you expect from, was it 2,000 pages, Mark? 17,000? I've heard it's thousands of pages of a piece of legislation like that. Perhaps a company providing the seminar wanted to panic the participants to encourage the use of consulting services. Perhaps they were equally confused as we were. We all had excuses. It was early in the game. So for about 1.5 years, I sat tight, trying not to panic. I then attended an informative and my very first practical seminar on Healthcare Act by our today's guest, Mark Rose. He made it easier for me to understand, and he tried to keep the politics out, and essentially said, this is the deal, like it or not. So briefly, let me just quickly bio on Mark. Mark Rose is a partner and the Director of Health Plan Compliance and Reform at the Partners Group within the Employee Benefits Practice. The primary focus of the TPG Employee Benefits Practice is to assist employers with all aspects of their group benefit plans. Mark is active at both the state and federal level. He is currently one of 6 governor-appointed directors on the board of the Washington Health Insurance Pool. Mark and his wife, Lisa, are active in the local community and busily raising their 3 children, a son they adopted in 2009 and 2 daughters. Mark, why don't you come on up here and let me finish my intro here. So one of my goals this year was to have a couple of presentations that were practical. One was a cocktail presentation. So I figured, why not AHCA, which is Affordable Health Care Act? The format today is the following. I will be asking Mark some ground zero questions. In between, we will be asking you for your questions during our conversation. The simpler and dumber the question, the better. I prefer we get to a lot of questions that have more common ground than some tricky questions to stump the speaker. Please, no compound questions or politically based questions. Our goal is to get some ground zero questions, not 30,000-foot questions. So we're going in reverse here. Perhaps Mark can stay after for some more questions. All right, Mark, let's begin. And thanks for joining us today.
Thanks for having me, Paul.
You're welcome.
So while Paul gets the mic going, he asked me if I could come with a stat or a prop or something that kind of shows how this bill's evolved.
Got it? There you go.
And we all saw that 1,200-page document that was used as a prop over and over about how big the bill was. At last estimate, the reason I couldn't bring a prop is at last estimate, with all guidance when it's finally released, that looks to be 170,000 pages. It's going to would be 68 feet tall if you stacked it up. And to put it in comparison about how big a deal this is, the entire Internal Revenue Service Code is 13,000 pages. So it's about 15 times the amount of printed material.
That's why it was hard to find someone like Mark who could boil it down. And if you recall, I think Einstein said if you can't explain it to a 5th grader or a 6th grader, you don't understand it yourself. So maybe I found the right guy. Well, let's find out, huh? All right, question number 1. We've all heard about the Affordable Care Act. And most of it, not all of us, have sat through presentations in the past year on it. Who exactly does this impact?
So that's an easy question because it's everybody. Unlike a lot of the things we had before, if you're just an individual, you're required to buy coverage in 2014. If you're a small business and you offer coverage, you have to offer an essential health benefits package that changes what's offered. And if you're a large employer, you have to offer coverage where you didn't have to before or pay a penalty. And the benefit changes that are required apply to both self-funded and fully insured plans. So this is going to impact everyone. And regardless of where you are, your costs are going to be slightly higher for the insurance that you do purchase or the coverage because there are fees included in it. So everybody gets impacted.
Thank you. You've analyzed the financial benefit impacts of the Affordable Care Act on your clients. So right now, Mark is presenting and selling packages. So it's going on right now. Their employees and their families. So what are some results you found that surprised you or alarmed you?
Well, there are two particular ones that I can think of. So we take our clients through a process just to determine the financial impact. What if anybody heard the phrase pay or play? So what if I play so I continue to offer coverage? What if I pay, terminate coverage, and pay the penalty? Well, we found a 150 employer group. There's a client of ours that it would cost them $45,000 more to not offer coverage. So think about that. How many of you have a service you buy from a vendor where if you stop buying that service altogether, it would cost you more than it would to buy it? And you haven't replaced the service you're getting. The second example that was surprising to us is we found examples of a very large group that if they were to stop offering benefits to all their employees, terminate them altogether, the employees would actually have better coverage at a lower cost through the exchange, and the employer would save a substantial amount of money. So they actually increased the benefits they were offering by not offering coverage. So what we took away from that, these first two real examples we looked at that way, is this isn't intuitive. So you need to do that.
It's not?
No.
Very good. Do you have one final thought you'd like to stress to our audience on the Affordable Care Act before I open it up for questions?
The one takeaway that I would like you guys to walk away and remember is we've all sat through multiple presentations. I've given quite a few, and they generally seem to focus on here is what's happening and when it's happening. You start with the timeline in 2010 and go on through. What I would suggest is that if you're involved with the purchase of health care for an organization or looking for your family, make sure you're getting advice from someone who's looking at how this directly impacts you. Real numbers, real statistics, real premium costs, real benefits, real impact on the families that you cover if you offer coverage to families. A lot of the stuff we see out there is general in nature, and there is no general solution. There's no general answer that fits one segment of the employment sector or individuals or every company and every set of employees covered by benefit plans are different.
Very good. Let's open it up here. Mark, let's take some questions from our members here. Remember those guidelines, please.
I've been told by several hospital administrators in the area that there's enough money in the system already to solve the health care problem. Is this act revenue neutral, or is it going to raise costs of health care for everybody?
Well, I'll be as brief as possible in answering that. So I don't think it's revenue neutral, because we're adding coverage access to 30 million people that didn't have coverage before. So there's a cost to do that. So I think if you look at whether or not it's going to be negative or positive price impact, if you have coverage currently, it's probably going to cost a little bit more because that's the way we're generating the revenue to cover those 30 million people that currently don't have coverage. So it depends on whether you have coverage or not. If you don't have coverage and now you're eligible for fully subsidized coverage through an exchange, it's a very positive thing. If you're an employer and you have 4% increase to your cost just to cover fees, it's a pretty negative thing. So it depends on who you are and what your situation is.
Wonderful. Next question, please.
For those of us that have small businesses, less than 50 employees, we're currently involved in a group of, that reduces our costs. Now we can't be a part of that group. So the folks are asking me, what's an exchange? How many exchanges will there be? And what can we expect in the way of costs for both small employers and for individuals?
Excellent question.
So technically, isn't that a compound question? No.
A little bit.
But it's a great question, though, because the exchanges are basically marketplaces. So they're places that people go to look for coverage. E-insurance is an exchange where you see everything all spread out. So the law required that each state establish an exchange effective January 1st, 2014, where coverage will be available to go to purchase. Now the value, because we've all got computers, or most of us do, where you can actually see what's available currently, is that the exchanges will be how subsidies are distributed. So if you qualify based on income for a subsidy as an individual, you can only get that subsidy by going through an exchange. Now, Washington we've built our own exchange. States had a choice, so we chose to actually establish our own exchange under the guidelines. It's going to be operational January 1st. Some states like Texas or Florida, they've let the federal government take over and do that. Now, for small employer groups, there's what's called the SHOP exchange, and that's going to be, it stands for the Small Health Options Program, and that's for groups up to 50 employees, up to and including 50 employees beginning in 2014 and up to 100 employees beginning in 2016. The benefit there is that you'll be able to have multiple plans available that your employees can choose from, but it's still on a group basis. I believe most likely the program that you're referring to is the association health plans. If like a WAHIT or Northwest Employers Trust, those type of things, many of those are going away, and employers will be required to go through the private market directly to purchase coverage.
Does it include U.S. territories? I know we say 50 states, but Puerto Rico, Guam, those places. Do you recall?
I honestly don't know.
Okay.
I haven't been asked
Next
that.
question, please.
Hi, thank you for being here. My question is, can you describe how this is going to affect Medicare and Medicare Advantage plans? Great
question.
So for the most part, the Healthcare Reform Act is not designed to impact Medicare and Med Advantage. So the requirement to purchase coverage goes through, does not apply to folks who are eligible for Medicare. So this law was really focused on trying to get everyone in that, really what they're looking at is the 18 to 29-year-olds, but 18 to 64-year-olds to purchase coverage or be covered under an insurance plan.
Mark, I'm going to ask him a couple questions, and I'm going to go right back to the audience here. Let's say I'm a 20-year federal employee with a great benefit plan. Does this act change anything that I'm getting right now, or is it exempt or separate?
Well, if you're a government employee and you're not so if you're a state or political subdivision employee, like a county or city employee, you're subject to the rules just the way any other large employer is. That you don't have to purchase through an exchange. Federal employees are supposed to, the Federal Employee Health Benefits Program, are supposed to go through the exchange to purchase their coverage. Now, one of the problems with that is that there were a couple gaps or loopholes when you write a 1,200-page document in a short amount of time and then have to use budget reconciliation to get it passed. Not everything gets addressed. So there's a problem with those federal employees taking their funding to the exchange. There really isn't a pass-through that was built into the legislation. And when they were trying to do a fix-it for it, they got a lot of negative publicity about trying to fix their own benefits program before they fixed ours. So I don't really know that there's been a workaround for that established yet.
So essentially they are affected one way or another, possibly?
Yes, they are.
All right. How about union plans?
Union plans, you have to offer coverage if you have union employees. There are some exemptions. For example, the highly compensated employee testing that eventually will be put in place. Unions plan can be exempted from that. Certain other provisions, they're allowed a little bit more leeway as far as they being able to class out from other employees. But union plans also have to participate, so there's not an exemption for not having to participate.
If I'm like 23 years old, super healthy, vibrant, and all those good stuff, is there a penalty if I don't want to sign up? I mean, how do you enforce some young person that says, I'm not signing up?
Well, that's one of the single biggest issues is the penalty for them. There is a penalty for not enrolling. So for every man, woman, and child, if you don't purchase coverage, the penalty in 2014 is $95 a year per person, or 1% of your annual income. And so the issue that I have with that is when I look at the numbers, I say we want to get these 25-year-olds covered. They're declining to purchase $300 a year insurance or a month insurance because it's too expensive, is finding them $95 a year going to influence them to spend $300 a month? So the penalties are 1% of your annual income is the top end, and it eventually goes up to a 2.5% of your annual income is the penalty.
Very good. Mark, can you go ahead? Well, wonderful.
Hi. I wanted to know how this impacts people who are having trouble or unable to get insurance because of pre-existing ailments or injuries or illnesses.
Great question. That's one of the benefit changes that came into play. So there are two sides to the plan. There's having to offer coverage, and then the other side is what's the coverage look like. So plans beginning in 2014 can no longer individually underwrite on the individual side, so they can't ask you health questions when you go to enroll. It eliminates pre-existing conditions. It allows for zero cost share on any fully insured plan for preventive services. So if I go have my annual checkup, I can't be charged a copay. I can't be charged any coinsurance. So it also makes all the plans that are offered guaranteed issue. So you'll be able to get coverage. And as such, the WISHIP program for the highest risk population, that'll be closed to new membership beginning in January, because those folks who were previously unable to get insurance will be able to go through the exchange of the private market and have guaranteed access to coverage.
So pre-existing, no problem.
Correct.
Question down there.
With this kind of complexity, how do we find advice and advisors that can help us make choices?
Well, I was specifically given rules about advertising for our firm during this meeting, so I'm trying to think about it. No. So, you know, it depends on the question that you're asking. So if you have multiple employer and you're asking a control group question, that's really something that your accountant would want to, that we would refer you to an accountant to determine whether you're a control group and have to aggregate employees for the offering. If it's an employee benefits and benefit design and compliance issue to make sure you're not suffering fees for affordability or minimum value testing, that's what we do, or other brokerage firms or employee benefits consulting firms do. And then there's, like for the highly compensated employee provision, when that's in effect, put in place, that would be a legal question where you would probably want to get legal advice. So it's going to depend on what the actual question is, but it's going to involve multiple advisors.
Jim Moore?
Thank you for being here and offering some advice. My question is, the Massachusetts plan has been, or I should say the Obamacare plan has been characterized as very similar to what was done in Massachusetts. To what extent is that true, and what has been the experience in Massachusetts with this kind of a plan then?
Real simply, yes. They did put a plan in place. It was interesting watching the presidential election last year because Romney actually was the governor when that was created. It has an exchange. It has some differences as far as it does have guaranteed issue. They had a very, very, very low, one of the lowest in the country, uninsured population when they established it, so the impact wasn't as great. The thing that's interesting, though, is one of our partner companies is based in Massachusetts that does what we do. And there really hasn't been much of an impact on the private market. The employers that were buying coverage through the private market still pretty much buy coverage through the private market. So I don't know that we can use that as a template to say this is going to have the same impact here that it had in Massachusetts.
Very good. Kirk?
Paul said simple and dumb, so here we go. If I have a company, we have 8 employees. We pay for their medical insurance. We have a kind of a standard, say, call it Blue Cross, Blue Shield kind of plan. So in January, what's going to happen to us?
Well, the couple things. First, you can continue to offer coverage. If you decide to terminate the coverage, there's not a penalty for that with 8 employees. If you continue to offer coverage, the coverage that you offer, it's kind of strange, but the groups under 50 don't have to offer coverage, but if they do, it has to include what's called an essential health benefits package. And so there'll be a slight change, usually an enhancement to some of the benefits that are offered. And then the rates are most likely going to include anywhere from 4 to 5%, maybe, and it varies, additional cost due to comparative effectiveness fees and other taxes. But you'll still be able to purchase coverage from Premier Blue Cross, Regents Blue Shield, and the shop that I mentioned, the small small employer exchange. That's only going to be available in Kamiakum, Clark, and Cowlitz County in January, because Kaiser is the only offering, and that's the only counties they offer in currently. It's tentatively scheduled to be offered sometime mid-year with more carriers that would be able to have it be offered across the state.
I'm going to ask one question, then I'm going to go right back to the floor. Looks like we're getting more questions from the audience, which is terrific. Long-term care rehab, is that covered?
Long-term care, nursing home coverage, that is not part of the mandated offering. Rehabilitation, so outpatient rehab, would be part of the Affordable Care Act or a benefit offering. Excuse me. And if it's determined to be an essential health benefit, there can't be any annual limits or any annual dollar limits on that.
Any incentives for preventive health care, I guess you call it? So I want to join a gym, I stop smoking, or I eat better. Are there any incentives to do those kinds of things?
Specifically for smoking cessation programs, there are, for large employers, there's a credit associated with offering that plan. So if you offer a smoking cessation program, that can be included in the calculation when you determine whether you're contributing enough to have it be technically an affordable plan.
All right, very good. Dave, you had a question here.
Yeah, as a small employer, we've seen our costs going up by double digits per year for several years. We have a high deductible plan. How will the new laws affect a company with a high deductible plan that's a company with a health savings account?
So for health savings accounts are still okay. So what they've done is they've established, HHS established that if you're a small employer below 50 full-time employee equivalents, you cannot offer a plan that has greater than a $2,000 annual deductible, $4,000 per family. And the total out-of-pocket, including deductibles and coinsurance, the percentage I pay when I go to the doctor, can't be more than the HSA limits for 2014, which are going to be $6,350 per individual or $12,700 per family. So if you have a $5,000 deductible HSA plan, for example, you would not be able to purchase a plan that had that high a deductible in the small market. So if you had to lower the deductible, that would increase, most likely increase the cost of the plan.
Quick question that involves, without regard to laughter, the IRS. Will the IRS be a mechanism for getting enforcement? Will you have to have a checkoff box that you have insurance or don't have it? Or are there any other mechanisms that are going to give the overwhelmed IRS and the overwhelmed health care authority some way to actually enforce?
That's actually a really good question. The healthcare authority to state level won't be involved in any way in the penalty piece. The IRS is actually the mechanism that will be used to collect penalties, and I believe it's where you're going to check a box on your tax return to say that you have coverage. There are no plans. The IRS has said publicly at this time there are no plans to have active enforcement with collecting the penalties. So, and I'm speaking purely for the individuals. There are active plans to do enforcement and collect penalties for employers with more than 50 employees that don't offer a plan or offer one that doesn't have minimum value. So if you think of that box you can check on the bottom of your tax form, do you voluntarily contribute to a campaign fund, $1? That's kind of, it's going to be a voluntary honor system contribution for the penalties. At this point, all that's subject to change though.
We all hear about the wild variation in pricing for medical services. Will this program have an effect of stabilizing prices from hospitals and healthcare?
Well, one of the things that I say about the act that was actually passed, the law, is the only real issue I have is they used the wrong title. It's called the Affordable Care Act, and it was the Accessible Care Act. It really is designed to get 30 million people to have coverage by hook or by crook. And so we need to have phase 2 that will work on cost, because there isn't anything necessarily that requires increased transparency from providers or hospital systems, or is going to directly lower the cost, other than the idea that if we increase competition, that may lower the pricing.
We have about 100 employees, and so we're in that, I guess, category above 50. And we've always differentiated between regular people that are full-time or near full-time, they get benefits, and then we have a lot of part-time people who might just teach a couple hours a month or something like that. Does that distinction go away?
No, it doesn't. Now, that changes slightly. So the definition of full-time, so once you do the calculation and determine that you have to offer coverage because I'm technically a large employer, then you have to offer coverage that meets minimum value and is technically affordable to all employees that are working more than 30 hours a week. So that's the full-time employee designation. Now, there are some exceptions. There are rules around variable hour employees. So a line cook in a restaurant that doesn't know his schedule week to week and works 25 one week and 40 the next, he's a variable hour employee. A hostess, 8 to 5, 5 days a week, that's not a variable hour employee. And so a few hours a month, that wouldn't be a problem. If it's 30 or right at the edge, you may have to change some of the people you offer coverage to.
Mark, thank you very much. And are you willing to hang around a little bit for a few more questions afterwards?
Sure. Yeah.
Wonderful. Thank you very much, Mark.
Thanks, Paul.
Seattle Rotary Online is made possible in part by a grant from First Choice Health, working with the Washington Health Information Collaborative to use technology to bring better health care to patients throughout the Pacific Northwest. First Choice Health.